Good afternoon, everybody. We're going to get started in about 2 minutes. If anybody that was just in the waiting room is a speaker, if you can just unmute yourself and identify yourself for us, or change your name on your Zoom.
Has started sharing. Have a great day. Thank you.
Great. Good afternoon, everybody. We're going to give it just 1 more minute and we'll get things started. Thank you for joining us today for North Carolina Rare Disease Day, virtual, as we are all now accustomed to, unfortunately. Okay, I think we can get started. Just again, welcome everybody. I have up on the screen our medical and legal disclosure, and I'll let you read this at your leisure. I'm not going to read it word for word. However, it just mentions that we do not provide, nor does an organization, and our volunteers and staff cannot provide medical or legal advice. I believe this will also be shared in the chat as well if you'd like to view it further. I'm going to now share 2 short videos with you, and then we'll get the program going.
I am Tristan.
Angelina.
Nawazay Shafiq.
Regina. Habari asubuhi, Javi. Jeg är Christian och jag bor i Norge.
I live in the United States of America.
In Australia.
Malaysia. No Brasil.
Tunaishi Kenya.
My passion is for fashion and design.
I love to dance.
Yusurutan. Para viajar e descobrir novas culturas.
Anapenda kunitazama nikipuliza mabovu. Jag älskar idrott och spelar spel med familjen min.
Minhas paixões são minha fuga quando as coisas estão difíceis.
Ada hari-harinya bila melakukan perkara yang biasa akan jadi sangat susah. When your disease makes you feel isolated.
It's difficult to walk. Och vara med på laget.
When I'm tired.
Afraid.
O controle da doença pode ser desafiador.
Atau mengecewakan bila saya kehilangan masa.
Muda muhimu sana.
But we learned to be resilient.
Para apreciar os pequenos detalhes que me trazem alegria.
Kumwona mtoto wangu wa kiume anavyofurahi tunapoenda nje, nikijua anasikiza hadithi na sauti zilizo karibu.
Mencari titik hubungan dengan masyarakat yang tak pernah saya sedar wujud.
Och vara överge på grund av mänskliga rutiner.
There is support.
Sua bondade inabalável.
Mina vänner.
Keluarga.
Enfermeiras.
Doctors.
Support workers.
Assistenter. Mashirika ya wagonjwa.
Together we are a strong community.
Nimeweza kuelekewa.
Histórias compartilhadas que me libertaram das dúvidas.
Vågar vara självtillit.
I am Tristan. I live with sickle cell.
I'm Angelina.
Leiomyosarcoma, câncer raro.
هويوني هارفي أنا SMA spinal muscular atrophy يمكن reais هرمي معفبة شعرات.
Esta é minha vida.
Sua Isaiah, and I have no other heart disease.
We are
Camila Mãe,
Nós somos fortes.
and we are proud.
Just one more.
The NORD Rare Action Network is the nation's leading rare disease advocacy network.
Sorry about that.
Welcome. I'm Peter Saltonstall, President and CEO of the National Organization for Rare Disorders, and would like to welcome you to our 2021 Virtual Rare Disease Day event. Before we begin, I'd like to send out a special thank you to all those advocates and others who have spent so much energy and time supporting the rare disease community. So thank you. The role of Rare Disease Day is to bring together advocates and patients from around the world to help tell the story about rare diseases. There are events like this happening virtually all over this country today, and some of the audiences that we're really trying to focus on are those in the state legislatures, where advocates and legislative people come together to understand the burden of rare diseases and the impacts it can have on them, and therefore build the appropriate legislation and pathway to make sure that bills are passed that support rare disease patients. As a matter of fact, NORD's doing that in a very focused way with rare disease advisory councils. We've got them set up down in 16 states and are building them in others. I think 2021 is going to be an interesting year for us. The reason I say that is because we've just come off of a very difficult year with a pandemic that's impacted the rare disease community in a number of different ways and has really shown some of the inequities in the healthcare system. For all of you that are watching today, the importance of the Rare Disease Advisory Councils is critical to the success of being able to communicate the story and the needs of the rare disease patient community. So in conclusion, I would really like to make sure that I recognize and thank all of those sponsors who have helped us make this day a reality. Without your continued support, none of this would happen. So a sincere thank you from all of us at NORD and the patient community. Taking part in events like today's are really important to the rare disease community, and we must always remember that alone we are rare, and together we are strong.
Okay. All right, I'm now going to introduce you to our wonderful volunteer North Carolina Rare Action Network State Ambassador, Patricia Sullivan, who has coordinated today's event and done a wonderful job. So Patricia, I'm going to hand the reins over to you and I'll get the slide deck up.
Good afternoon, everyone. Thank you for being here today. As Kristen said, I'm Patricia Sullivan, and I am the Volunteer State Ambassador for North Carolina. And just want to welcome you to our North Carolina Rare Disease Day. And one announcement that I wanted to make before I reviewed our agenda was we are looking for a few more volunteers, if anyone would be interested in serving as our community engagement liaison, or we also are looking for a co-ambassador to work with me. Please let me know and we will follow up with you. So we have a very packed agenda today, a lot of great speakers. Unfortunately, we had hoped to have one of our lawmakers here, or a few of our lawmakers here, and that was not able to happen due to the General Assembly needing to be in session at this time. So let's go to the agenda. We're going to review the state report card. If you're not familiar with the state report card, NORD does put out a report card on some critical healthcare needs for each of the states. So we're going to go over that. Then we're going to share some patient stories. And then we have NORD students for rare. Then the Rare Disease Advisory Council for North Carolina. Then we're going to talk about supporting the rare disease community. Some speakers from certain agencies that help support us in different ways, including rare disease drug development, patient care models, as well as a patient airlift service. And then we're going to follow that up with a question and answer session. And then I'm going to make an announcement about our raffle. And then our closing, and I'm going to list some resources for you. Next slide. Kristen, next. Okay, thank you. And our speakers today, I will introduce them formally when they're about to speak, but we have Lucy Dunning, Macy Vanek, Stephen Lehrman, Dr. Jeffrey Mockney, Gwendolyn Johnson Ellis, Ontario McAllister, Teresa Balazzi, and Susan Candela. So at this point, I'm going to hand it over to our manager of state policy for NORD in the Eastern region, and that's Anissa Reed. So you're on.
Yeah. Hi, everyone. Thank you so much for joining us today. Of course, my dog decides to go off right now, so I apologize if you hear that in the background. So let's kind of start with the problem. So more than 25 million Americans are living with one of the more than 7,000 unique rare diseases. So that breaks down to about 1 in 10 Americans. So even though that may seem like a lot, state decision makers still have limited awareness of the issues and impact that rare diseases have on patients, their caregivers, and the overall healthcare system. So next slide, please. Perfect. So what is the solution? NORD believes it's to create rare disease advisory councils. So that's a diverse body that advises state government on the common issues that the rare disease community faces. So we see this as an enormous opportunity for government officials and the rare community to work together to develop resources necessary to prevent and address barriers in a strategic way. So there's a number of differences between state RDACs, such as the number of members, what the duties section is, so what the council focuses on. So overall, each RDAC has the same goal, which is supporting the rare disease community by increasing the voice of rare disease patients and caregivers at the state level. Next slide, please. Perfect. So to date, 16 states, including North Carolina, of course, which was the first RDAC to be implemented in 2015, have passed RDAC legislation. So we have several other RDAC bills that are currently being heard in other states as well, which is really exciting. Next slide, please. Great. So as mentioned, we're thrilled to have passed RDAC legislation in several states, and we want to continue increasing this number to give as many rare disease advocates a voice in state government as possible. So NORD highly encourages that different state RDACs collaborate with one another to share ideas and best practices. We plan to continue to develop and release toolkits and one-pagers, host webinars, and convene additional meetings to support ongoing RDAC work. Next slide, please. Great. So now I am going to jump into an overview of an important tool that we use at NORD. In 2015, NORD launched its state report card project with a goal of evaluating how effectively states are serving people with rare diseases. So this year marks the 6th edition of the state report card, which was compiled using data as current as November 2020. So these are the policy issues that NORD's report card focuses on. It's really important to note that these issues are not exhaustive. These issues touch on several critical and relevant policy areas at the state level, but with each issue included, there are still many others that are capable of impacting the lives of rare disease patients. Next slide, please. So how do you find out where your state measures up? So you can select your state by clicking the link that is right there. Each state's page is also available in a printable version. So I'm not sure if we're able to play this little video. It does a quick overview of how to navigate the state report card.
I will press play. If the sound is not good, I will just stop the video and.
So here we have the landing page for the 6th edition of the NORD State Report Card. We've just got a little intro text up here, and then we have the 8 issues that we assessed in the 6th edition of the report right here. If you go over here, we have a drop-down bar where you can click and select your state, and then right underneath of that, we have all of these patient stories. About some of the issues that are focused on in the report card. So now I'm just going to navigate to one of the issue pages. I'm going to click Medicaid Financial Eligibility, and that'll take you to this individual issue page. We just got a little bit of intro text again at the top, and then some more text about what the issue really is and why NORD cares about it underneath. Then we have some text about the grading methodology for this section, as well as the rubric, which is available at the bottom and also underneath of the map right here. Again, we have that drop-down bar where you can select your state. Then if you go to the left over here, you can click and access all of NORD's policy statements on the particular issue. And then you can also click and access the appendix for that section. So next, I'll look at the map a little bit. So you can hover over each state on the map and see the state's overall grade, which is bolded there for this section, as well as the subgrades that were averaged together to get that overall grade. If you click on any of the states, it will take you to that state's individual state report card page. So I clicked on Virginia, and here is Virginia's state report card. If you scroll, you can see that we have all 8 sections and their overall grade up here in orange, and then the subgrades underneath. And you can also click this right here if you want to open a printable version of the individual state report card.
Great, thank you. So there are, again, these are just some small snapshots of some policy issues that impact the rare disease community in 2020. So current legislation and changes that have been made so far in 2021 have not yet been captured. So if the state recently passed legislation to improve one of the policy issues, they might not have a high grade in our 6th edition yet. So you'll likely see it change when the 7th one comes out. So the website really just provides a detailed overview of the data, as you saw, and you can learn more about each policy issue in the methodology section. And Kristen also dropped the link in the chat, so you can save that if you want to take a deeper dive into that a little bit later. Perfect. So if you have any questions about our report card, then you can always send us an email at policy@rarediseases.org. Great, so I'm excited to now turn it over to our speakers. So I am pleased to introduce Lucy Dunning, who is the owner of Blue Sky Family Counseling and Coaching, who will be sharing her story.
Good afternoon. Bringing a baby girl into the world should be an experience of absolute joy. An expectant mother dreams of the days after delivery. I would hold my daughter, I would rock her to sleep. How then could that moment of joy end in chronic pain so severe I couldn't pick up my 7-pound baby? My name is Lucy Dunning, and I have a rare disease called complex regional pain syndrome type 2. It is the most painful disease in the world, and though I live with it every day, that's not according to me. It's according to the McGill Pain Index. There is no cure. In some cases, the only treatment is amputation. It breaks my heart to report that my pain journey started on July 6, 2017, my daughter's birthday. I knew there was something wrong immediately after the C-section, but my concerns were ignored. In that instant, I transformed from an active 35-year-old working mother to a woman who could barely walk. What should have been one of my happiest days instead became a life sentence of pain. I've been to the emergency room over 20 times in 2 years. I met with 8 specialists in North Carolina. I had had 4 surgeries in only a year and a half. In the beginning, not a single medical professional could identify the issue. Imagine being told by a doctor, I would just have to live like this. But there was hope. I had a family doctor who believed in me. She didn't treat me as another patient. She treated me as a person who needed help. She showed me how to become my own advocate. My research, born by her advice, took me to a doctor in Maryland. After years of pain and waiting, that doctor was immediately able to diagnose me with complex regional pain syndrome type 2. It's not an easy diagnosis to receive, but it was an answer, a diagnosis that has led me to 3 nerve surgeries. I am not restored, but I can walk again. My quality of life is now 60% of what it was before that C-section. I wonder if it could have been higher. I want to talk to you about the barriers that prevented me from getting a timely diagnosis. I was stigmatized by doctors who were supposed to help me. Their lack of awareness of rare disease led them to believe my disease was not even physical. They turned to my mental health instead, saying my disease was, quote, all in my head. I will never know what my life could have been had I been diagnosed earlier. Research shows that the earlier nerve damage is diagnosed and treated, the higher your chances of correcting the issue and avoiding lifelong debilitation. It took 7 months and 15 visits to the emergency room before I was even referred to a specialist. The earlier diagnosis can only happen if doctors are aware of rare disease and educated on preventing bias, treating patients as people with dignity, focusing on the real pain, the real problem, instead of casting them off as another patient with a mental health issue. Thank you.
Thank you, Lucy. And I also want to just add also that in Lucy's psychotherapy practice, she specializes with patients who do have chronic pain, as well as issues around grief and loss and trauma, which are common themes for those of us with rare diseases. And now I thought I was going to share a little bit about my story before we moved on to Macy.
Sorry, Patricia. I'll just leave this one up since I don't have another slide.
It's fine, Kristen. So I was diagnosed in February 2019 with a rare pituitary disorder called acromegaly, which is typically in 99% of cases caused by a benign brain tumor. And what happens with acromegaly is your body is producing way too much growth hormone. If it happens in childhood, it's often referred to as gigantism. So my journey with acromegaly, with having a rare disease, happened shortly after I moved to North Carolina. I had uprooted my life of 35 years in California and moved across the country to start the next chapter of my life. And about 3 months after I got here, I went to see my new dermatologist for a skin cancer scare. And I walked into her office and she grabbed my hands and she sat me down at her table. And I remember thinking, this is just the weirdest dermatology appointment I've ever had. Why is she holding my hands? And she looked at me and she said, I think you have a rare pituitary disorder called acromegaly. And in my typical fashion, I argued. She was not telling me information I wanted to hear, so I said, no, that can't be. And she'd bring up a symptom, I'd have some rationale for it, and she would say, no. So finally she pulled up on her laptop the diagnostic criteria for acromegaly. And I realized that all of the strange, weird symptoms that I had been having for about 5 to 6 years, all of a sudden made sense. So frightening sense, but started to make sense. And like many people with a rare disease, I had lived with symptoms. 2 of my symptoms were chronic, this incapacitating fatigue. Some days I couldn't even drive without falling asleep behind the wheel. So I would just have to stay home, and I kept gaining weight. So I kept being told, oh, you're just getting older. So a lot of my symptoms are just getting swept under the umbrella of you're aging. My hands had grown larger, my feet had grown larger, some of the things that are typical with acromegaly. But there's such a strange cluster of symptoms, I didn't piece them all together. So I was very grateful for the revelation from my dermatologist, though I was overwhelmed with anxiety and uncertainty about what this meant. I only had a couple of close friends here in North Carolina. My entire support system was still back in California. And here I was facing the possibility, the knowledge, not even just the possibility, of needing to have neurosurgery to remove a brain tumor and then adapt to living with a rare disease. So luckily, I was connected with a very knowledgeable endocrinologist at UNC. And the minute I walked into his office, he said, "Oh, I don't even need to do a workup. I can tell by looking at you that you have acromegaly," which honestly was not very comforting because I realized then how much my physical features had probably changed. But it was also reassuring that I was in great hands. So, and in my naive way, I believe that having the tumor removed would mean the end of having acromegaly. And that isn't the case. As often with acromegaly, successful removal of the tumor means you still are symptomatic. And even after the tumor was successfully removed in April of 2019, my body still misfires and still produces too many growth hormones. So that started my journey of orphan drugs, 2 of which gave me horrible, horrible side effects. Until I finally could land on the medication that could actually control the production of growth hormones for me. And unfortunately with acromegaly, which I think is often true with other diseases, you usually are not diagnosed until further down the line. I had probably had acromegaly for at least 15 years. So all the other health concerns that are associated, the comorbidities that go along with acromegaly, some of them are also present, such as high blood pressure. So I kind of went through my own process. My background was in psychology. I was a licensed marriage and family therapist in California. So I had a lot of the tools that I needed, and I had worked in healthcare. So I felt like I had a lot of the tools that I needed to navigate the system. But I think the anxiety and the duress and the stress of having been diagnosed with a rare disease, even with all of my tools in my toolkit for coping, was still very overwhelming. And so I'm very aware of how the diagnosis can not only impact someone physically, but also impact you emotionally and psychologically as you brace to live a life with a rare disease. So I kind of had to work through that part of it, but part of my journey for healing was to turn around and think, how can I turn what seems like a basket of lemons, so to speak, into lemonade? And so about a year after my surgery, I reached out to NORD to become the North Carolina State Ambassador, thinking I wanted to give back to the community. A new community for me, nonetheless, but I did want to give back and also give back in my new home, which was North Carolina. So that was my journey with acromegaly. I'm still dealing with the ramifications, obviously, of having it, but trying to move forward in a very positive way with what I thought would be the easy last 3rd chapter of my life, roughly, if my genetics are what I think they're going to be in terms of family history, with this whole new chapter that I'm now having to write for myself. So that's my story, and that's a little bit of my background about how I came to be the state ambassador. So thank you. Okay, so now we could have next slide. please. So now I'd like to introduce Macy Vanek. She serves as the outreach coordinator for NORD Students for Rare at NC State. And with that, I will turn it over to Macy.
Hi everyone, my name is Macy Vanek, and like Patricia said, I'm the NORD Students for Rare Outreach Coordinator at NC State University. I'm going to be sharing a little bit about my personal story in NORD here at NC State. So I'm going to start off with a little quote that I have. Your trials and tribulations are more precious than gold, because your trials build your character. This became my life motto at the age of 16 after I had ACL replacement surgery. Prior to my surgery, I was running probably 8 to 9 miles a day, playing lots of sports. But afterwards, I had to spend a lot of time sitting down. This new sedentary lifestyle led me to develop CRPS, complex regional syndrome, which Lucy had just talked about before, that directly affects your nervous system, causing it to be stuck in fight or flight mode. So like she was kind of explaining before, the physical symptoms are variable from person to person. For me, I had lots of burning and pain in my lower extremities. I was also very dizzy and I had a hard time focusing in school. But over this last summer, I had a friend who asked me to join the board of NORD chapter at NC State. And so I jumped on this opportunity as I knew my experiences with rare disorders would help me benefit the community more. If you want to change the slide. So last semester we started the NORD chapter at NC State from scratch. And as you can guess, it was very hard to start a new chapter during COVID. We couldn't do lots of outreach events and there was no one on campus to reach out to. But we knew people at NC State were suffering from rare disorders just like I had in the past, and I know others and their families were suffering. And as people were making career decisions, we wanted them to be as educated as they can about rare disorders so that way they could learn to advocate better for them. So we had Dr. Jesse Boehm, the scientific director of the Cancer Dependency Map from the Broad Institute of Technology, come speak to us about his work with CRISPR technology in the rare disease space. We also had Barbara Van Hare from RCRF, the Rare Cancer Research Foundation, come talk to us, and she also works with pattern.org, which is an organization that encourages people to donate their tumor tissues to cancer research. And she also talked to us about the Broad Institute of Technology Rare Cancer Dependency Map project and her work with cancer genomics. Another notable speaker we had was Patricia Sullivan, who just told us her story. We also had her share her story with us so that way we could further educate people and instill the same passion that she has for rare diseases as they continue to make their career path decisions. Currently, we're looking to host our own Rare Disease Day collaboration event. We're working with the UNC NORD chapter and the Wake Forest School of Medicine chapter. And we're also working with a high school out in Texas. And we are hosting many guest speakers, and we're looking to promote some charities. So we've worked with Barbara Van Hare from RCRF to create some t-shirts that we're looking to sell at our event in order to raise money for RCRF. So as I reflect on the trials of my life, they've helped me have a greater passion for NORD and drive to reach out to people. I do have a similar situation and story as Lucy just talked to us about, but I finally found a doctor and a physical therapist that were able to listen to me and help me return to a higher quality of life. As you can see, I'm able to speak to you today. I'm able to excel at a physically demanding job, and I'm a successful student at NC State, which I didn't think a couple years ago I would be able to do. In conclusion, here at NC State, we're hungry for opportunities, especially in research and volunteering. Don't be afraid to reach out to my email that is listed above if you have any questions or comment about our work at NC State or my personal story. Finally, let your trials move you and push you to be a better person. Your trials and tribulations are more precious than gold because they build your character. Thank you.
Thank you, Macy. Thank you very much. Okay, so next I would like to introduce Stephen Lehrman. Stephen is the grandfather of Courtney, who is affected by CLN2 Batten disease. And he's also a member of the North Carolina Rare Disease Advisory Council, serving as the leader for the task force reports for the council. So with that, I am going to turn it over to Stephen. And thank you, Stephen, for being here today.
Thank you, Patricia, and hello, everyone. Can you see me? I'm still seeing Patricia.
We can see you, yeah.
We can see you. We can hear you good.
Okay, okay, great. So again, my name is Stephen Lehrman, and I'm going to talk to you today about the North Carolina Rare Disease Advisory Council. Next slide, please. This is a photograph of Taylor King. As a teenager, Taylor was diagnosed with a late onset form of infantile Batten disease. Unfortunately, in September 2018, at the age of 20, Taylor passed away. She's survived by her parents, Sharon and Jim King, and sister and brother and their families. And the legislation that authorized the establishment of the advisory council is named in Taylor's honor. Next slide, please. So how did the advisory council get started? In late March of 2015, Sharon King and other rare disease advocates hosted a legislative breakfast. And the photo on the right is a picture of Sharon standing at the podium. The purpose of the breakfast was to introduce to members of the General Assembly the idea of starting a North Carolina Advisory Council on rare diseases. And the bill was filed in mid-April of 2015. And the photograph in the middle is a photograph from left to right of one of our sponsors, State Senator Lewis Pate, Sharon King, another one of our sponsors, State Representative Becky Carney, and Tara Britt, who is our Associate Chair of the Advisory Council. So the bill was passed by unanimously, and the council began work in late 2015. Next slide, please. We have 10 members of the Advisory Council. Our chairman is Dr. Bruce Cairns from UNC School of Medicine. The Honorable Rufus Edmonston, who was former North Carolina Attorney General and Secretary of State, serves on the council, as does Sharon King, founder of Taylor's Tale. Dr. Vandana Shashi, who is at Duke University Medical Center and is the principal investigator of the Undiagnosed Disease Network. Dr. Mike Knowles is a clinician at UNC Hospital and UNC Medical School who focuses on rare pulmonary diseases. Next slide, please. Dr. Arvind Asokan is a world-renowned specialist in gene therapy. Brenda Nielsen represents the council as our registered nurse. Dr. Mark Benton is the Deputy Secretary for Health Services at the North Carolina Department of HHS and is an ex officio member. I lead our task force reports, and Tara Britt serves as Associate Chair for the council. Next slide, please. The overall goal of the council is to leverage North Carolina resources to help rare disease patients. Next slide. The council advises on coordinating state efforts for the study of rare diseases within North Carolina. and the council reports to the Secretary of DHHS, the governor, and the Joint Legislative Oversight Committee and the General Assembly on our activities and findings and recommendations for rare disease research and care in North Carolina. Next slide, please. The council has developed 3 reports. The first report was in early 2018, where we looked at newborn screening and early intervention for the treatment of rare disease in North Carolina. We concluded that North Carolina was not doing a very good job on newborn screening. And in fact, based on the number of conditions and the fee charge, was in the lower quintile of all states, and especially those in the Southeast. About the time that we issued this report, the North Carolina DHHS issued a report of their own, which looked at the structural financial deficit of the state lab. And these 2 reports, in conjunction with a vigorous lobbying effort on the part of our North Carolina biotech industry, convinced the General Assembly to update the newborn screening program in North Carolina. The legislation that was passed in 2018 added 3 new conditions to the state panel: XALD, Pompe, and MPS 1. And since then, SMA has also been included in the state panel, and increased the newborn screening fee to cover the state lab cost, and also created a dedicated fund to purchase new equipment and training. Next slide, please. Our second report was, we looked at the access to genetic testing for rare disease. We highlighted in the report that there was only a small number of clinical geneticists and genetic counselors in North Carolina. This was not atypical for North Carolina. It was actually pretty consistent across the United States. And we also reported that there was a lack of coverage from North Carolina Medicaid for genetic testing in general. Much of the information that we reported in this particular paper contributed to the section on genetic testing services that was included in the 2020 North Carolina Public Health for Genetics and Genomics Plan. And last slide, please, or next to last slide. The most recent report that we have written is, we looked at the impact of COVID-19 on North Carolina rare disease patients. This report synthesized a lot of publicly available information, as well as we received some input from our North Carolina rare disease community and medical and hospital providers. The report borrows heavily from 2 surveys that NORD conducted last year, and that, in conjunction with other information that we found, gives a pretty good picture of how serious COVID-19 has affected the ability of rare disease patients in North Carolina to receive good treatment. Last slide, please. So on behalf of the North Carolina Rare Disease Advisory Council, I'd like to thank NORD for inviting us to come and talk to you today. If you have any questions, you can contact Tara Britt, who is our Associate Chair. That's her email there, and also the website for links to our council. Thank you.
Thank you, Stephen, for being here today.
Patricia, we have one question. I think I'll just, that just came through the chat for Stephen. Are these reports available online on the website somewhere?
Yes. So the first 2 reports on newborn screening and on access to genetic testing are available on the website at that ncraredisesesnetwork.org. The third paper on COVID-19 has not been posted yet.
Thank you.
Okay, now we can do, okay. So thank you, Stephen. And I thought I would just take a few moments to talk about why we need rare disease advisory councils. As has been already mentioned, North Carolina was the first state to have a council, which started in 2015. But they're important to have because a rare disease, first of all, let me give you a little background on rare diseases, which most of you probably know. A rare disease is any disease, disorder, illness, or condition affecting fewer than 200,000 people, and that's within the United States. And there are approximately 7,000 known rare diseases. And it's also estimated that 25 to 30 million Americans have a rare disease, which is almost 1 in 10. Most rare diseases are genetic or have a genetic component, and more than 90% of rare diseases are without an FDA-approved treatment. There are more than 500 types of rare cancers, and all pediatric cancers are rare. So next slide, please. Rare disease advisory councils give rare disease patients a unified voice within the state government by helping to provide educational awareness and make recommendations to elected and state leaders on how rare diseases are handled and treated in the state. Next slide, please. And in 2015, the first RDAC was created in North Carolina by patients, caregivers, families, and providers, as Stephen mentioned. And it was House Bill 823, an act establishing the Advisory Council on Diseases within the School of Medicine at UNC Chapel Hill. It was ratified by the General Assembly on July 29, 2015. And the governor signed this legislation on August 5th, 2015. And the legislation received bipartisan support and passed unanimously through the NC House and Senate. Next slide, please. Since then, rare disease advocates and stakeholders have sought councils in other states to help better represent their communities. NORD is working to establish well-organized, high-functioning rare disease advisory councils in every state to support the needs of the rare disease community. NORD launched Project RDAC in November 2020 to optimize existing RDACs and help more states enact legislation. I just want to add, as Kristen has mentioned also previously, and Anissa also mentioned, we are working throughout the country now to enact the, sorry, my cat just decided to scratch my leg for a second there. I wasn't falling off the chair. NORD is working to enact RDACs across the country. So there's a lot of work being done. And I think that I just want to give a shout out to Stephen and our RDAC. Because of the hard work that you've done, we've become a model for other states. So I just want to acknowledge that and your leadership in that role. Okay, so now we are going to move on to perspectives on supporting the rare disease community. And we're going to have 3 speakers, actually 5 speakers for this. We're going to begin with Dr. Jeffrey Mockney, and he is the Senior Vice President of Regulatory Affairs at ProEd Regulatory. And
yes.
That's, yes?
Good afternoon. Thank you so much for that introduction. I appreciate it.
I'll let you explain that a little bit more than I have.
No, my name is Jeff Mockney. I'm Senior Vice President of Regulatory Affairs at ProEd Regulatory, which is an organization that is dedicated to help the pharmaceutical industry help move drugs to market. And what I was hoping for and wanted to do was, share with you a perspective that comes from the idea of a regulator and drug developers perspective. And specifically,
I'm sorry, I didn't mean, I was telling, next slide, please.
oh. Yeah, thank you.
Yes.
And specifically, I wanted to talk to the audience today about a change in our mindset from the benefit risk to a benefit value proposition around rare disease drug development. Next slide. I think we can go one more. And there are really three perspectives that I'd like to share. First is I'd like to start with a brief introduction to that benefit risk and drug approval and the role that that plays, and then how we might be able to shift our mindset and encourage the pharmaceutical industry and our regulators and our legislators to provide some more opportunity for the future of rare disease therapy. Next slide, please. I'd like to start with saying that drugs reach market are chiefly two issues. The unmet need in the population and the benefit a drug provides to those indicated populations. Here in the US, the FDA weighs heavily the inherent demonstrated value and benefit of a drug versus the risk it may pose and the duration of those benefits to the patients that are taking those drugs. But we need to ask ourselves, what really defines the benefit risk? And certainly the benefits that a medication can provide, it's also measured in terms of the risks and harms they pose to persons taking them. And we're left with asking ourselves this question: what is reasonable in that regard? And we're faced with the rule of rescue, which states that beyond practical considerations, there is a strong impulse to prioritize treatment for conditions that are severe and may disproportionately affect populations. And how that rule is applied to drive coverage policy, pricing, and access to orphan drugs is a continued debate in all of our circles. But perhaps the solution might be to shift that thinking rather in terms of benefit and value that drugs or platforms that therapy can provide. When we consider cost, benefit, and how indications can expand with time, certainly there are mechanisms in place that the FDA encourage drug development through financial incentives, but the burden of proof to satisfy the benefit and risk still remains. What is the benefit which provides value? Finite resources inherently cause tensions around allocations, leaving us to ask who's prioritized. The many or the few. And perhaps a simpler thinking for all of these issues is around the value of that benefit. But how do we measure that? Is it quality of life? Is it financial? Is it therapeutic? Or is it the applicability of the treatment to many diseases? Next slide, please. So in thinking about benefit and value scenarios, a good illustration might be in the Ontario policy. Now, in this policy framework, we see that unmet needs, benefit, and risks are evaluated, but they're also evaluated in terms of their value. The system they implement weighs costs, duration of benefit, and the quality of the invention, but it's based in an archaic thinking to some degree, in that it uses the current thinking around how we approach rare disease therapy, where we treat symptoms, but not necessarily the disease. I think by this thinking, what we're doing is locking ourselves into asking questions around intervention timing and duration rather than affecting the cure. Now, bringing it back to the US, we see that there's no magic solution because pharma and traditional approaches can never make the perfect drug. Even though considerable resource has been invested through the FDA PDUFA measures of patient-focused drug development meetings to understand the patient needs, understanding what healing looks like, working to understand the burdens, the values of therapy and treatment goals through the eyes of the patient and the regulators. What is the value, though, in the economics of therapy? And how do we justify the cost of treatment as a long-term solution when what we really need is a cure? Let's consider that on our next slide. So in our first build, if you wouldn't mind advancing one, there's a build, yeah. Drug development using chemical entities for therapy cannot cure the disease. Would you mind building again? We manage the symptoms of the disease in our rare diseases. And for right now, this is the best we can do in broad terms. But I believe that gene therapy represents a viable option for the future of medicine for rare diseases. Would you build one more time, please? And again? Thank you. In thinking about that and looking at rare diseases and thinking about the genetic therapy options that are available, I believe what we need from our elected officials to accomplish this is increased support and incentives for gene therapy approaches and move away from the thinking about a single cure, but to developing platforms. And this platform development with continued support for accelerated approvals to satisfy the needs of the patients who desperately need novel and less toxic therapeutic approaches. It also satisfies our rule of rescue hypothesis by providing long-term care, long-term effective therapy at what we hope will be reduced cost. Now, we oftentimes forget that the first pill that comes off the manufacturing line costs nearly $1 billion to develop. But the truth is the second pill costs 1 cent. If we can effectively spread the cost among the therapy group and think of delivering therapy platforms rather than single disease state therapy treatments, we have a real chance of reducing the burdens of cost and eliminating the health inequities that exist in populations. So while all of these things are absolutely important, it takes a village, and it takes all of us as part of this rare disease community to look for novel solutions and help voice that to the regulators, our legislators, as well as the pharma industry to help our patients move forward. I thank you for just the few moments I got to spend. While I don't suffer from a rare disease, or thankfully anyone in my family, I've been involved with the research around rare diseases for a number of years in my career, and specifically working with CF. And it's been a very rewarding experience, and I look forward to continue supporting the community and seeing all the new novel advances in science and treatment that come out. So thank you very much for the time to share. Much appreciated.
Thank you. Thank you for your presentation. Okay, so now we have 3 presenters from the North Carolina Department of Health and Human Services. We have Gwendolyn Ellis, Ontario McAllister, and Teresa Balazzi, and they are educator counselors in the North Carolina Sickle Cell Syndrome program. And one of the reasons that I'm excited to have them here today is I know in a lot of my conversations around rare disease, there's a certain sentiment that is echoed about getting the information that one has a rare disease and then what? And I know I experienced this for myself. I remember thinking, could they just give me a brochure about acromegaly? Something, you've given me this diagnosis, now what do I do with it? And I think that it's important for us in the rare disease community to look at patient or client service models that might actually be able to be replicated or used to help patients navigate the system once they do have a rare disease. And the North Carolina Sickle Cell Syndrome program, I think they kind of have a model for how to do that. So I'm very excited to have them present today and share their model, their client service model with us. So with that, I'm going to hand it over to them.
Hello, everybody. I'm so glad to be a part of the Rare Disease Awareness Day. I'm so glad to be a part of this. And like the last presenter said, it does take a village. And I'm so glad to be a part of that village. And so like you just introduced, I am Gwendolyn Ellis, and I brought along with me a couple of my teammates to help me out in this presentation. So the North Carolina Sickle Cell Syndrome Program is a government-appointed a council for the sickle cell disease and other blood disorders. And it was established in 1973 through the state legislation, House Bill 32. This program is part of the North Carolina Health and Human Service Division of Public Health. It is a comprehensive clinical care coordination services to those that are affected with sickle cell disease. The sickle cell program provides genetic counseling as well as, and it's offered to the general public of individuals that are diagnosed with the trait or the sickle cell disease. Next slide. The statistics that I'm reading, they range from, I believe they're 2017 to 2019, but approximately 100,000 people have sickle cell disease in the United States of America. Sickle cell trait affects an estimated of 1 out of 3 million people in the United States, and it occurs approximately about 1 of every 13 African American. There is an estimated 1 of every 365 African American children who are born with the sickle cell disease. Now, the North Carolina Sickle Cell Syndrome Program, we serve approximately 6,064 residents with the sickle cell disease and the sickle cell trait. Next slide. There is approximately about 114 newborns who are born in the United States with sickle cell, with an abnormal blood disorder. Ontario? Next slide.
And the North Carolina Sickle Cell Program is divided into multiple service regions. Each county in the state is either covered by educator counselor or PMOT Health Services. Currently, the educator counselors are Naomi Moore, James Rogers, Gwendolyn Ellis, myself, Nadine Quick, Teresa Balaze, Susan Johnson, and Teresa Walker Brown. Next slide, please. The North Carolina Sickle Cell Syndrome Program services are screening and follow-up, counseling, care coordination, medical care, the DPH Sickle Cell Benefit Program, and also we do education and outreach. Teresa?
Thanks, Ontario. I'm Teresa Balaze, and I'm going to discuss here the services that we provide regarding the screenings and the follow-up procedures with infants that have an abnormal screening for sickle cell disease. And just to give you some background information here, universal newborn screening began in 1994. However, that's not to say that some states were not already providing this service. Screenings are done at birth by hospitals, local health departments, and providers. And typically this service is provided before newborns leave the hospital. There's a heel prick completed that's then sent to the state lab for testing. And if that test comes back abnormal, then the North Carolina Sickle Cell Program will contact the medical provider regarding any blood disorder classified as sickle cell disease. Also note that the newborn screening results are maintained by the state lab for 5 years for all infants that are born in North Carolina. Next slide, please. Here we have the 6 comprehensive medical centers here in North Carolina. In the far west, we have Mission Hospital, which is in Asheville, North Carolina. Moving back over towards Charlotte, we have the Carolinas Medical Center Atrium Health, which is in Mecklenburg County. Also, we have the Wake Forest Baptist Medical Center, which is in Winston-Salem. And Orange County and Durham County, we have UNC Chapel Hill, and we also have Duke University Medical Center. And then in the far east, we have the ECU School of Medicine, which is located in Greenville, North Carolina. Next slide, please. We also have a benefit plan with the DPH. It's called DPH Sickle Cell Benefit Plan. It was formerly known as the Purchase of Medical Care. It's the same plan. The name just was changed. These are some of the services that we provide: outpatient services, emergency room visits, medical equipment, inpatient services, medications, and dental services. And this is income-based. It's based on your income, and there's some guidelines for that. Next slide, please. And we also have a governor's appointed North Carolina Council on Sickle Cell Disease and Other Blood Disorders. It's a 15-member advisory group, and those that serve on this board consist of state, local officials that are interested in public health, teachers, members of the state, local school boards, persons or relatives with sickle cell disease, also community-based organizations, and of course the hematologists, which are the experts in treating sickle cell disease. We have a good representation from the medical viewpoint. We have the patient perspective as well as the community's perspective. So it's a wonderful council. They do a lot of great things, and it's wonderful to have that. And I think that is, next slide, please. I think that might be the end. Okay, Gwen, did you want to give information on how to contact?
Yeah, and so this is our information. If you guys will want any more additional information, you can contact us through these number. Our office number is 919-707-5700 or fax. And then that's the link for even more information. And thank you again, Patricia. I appreciate it, and I hope we can join again next year, and then maybe bring in some of our clients that are living well with sickle cell.
Yes,
thank you.
Thank you very much. Thanks for joining us today.
Thank you.
Thank you. Okay. So now I'm going to introduce Susan Candela, who is an experienced mission and outreach coordinator for PALS, which is the Patient Airlift Services. She has a strong history of working in the nonprofit sector, and she also holds a BS in sociology from New York State University in New Paltz. So with that, I will hand it over to Suzanne.
Thank you so much, Patricia. Can everyone hear me?
Yes.
Okay, perfect. I had an issue yesterday on a Zoom call with my audio, so I'm glad it's working today. Thank you guys so much for having me. I'm so excited to introduce everyone to PALS, especially those of you who are unaware of volunteer pilot organizations. I'm glad to be able to have this opportunity to kind of educate you on what we do. We've been a great resource to many rare disease communities, and our goal is to expand and help many more people in need and just get the word out. You can go to the next slide, please. So PALS is, like I said, we're a nonprofit organization. We're something called a volunteer pilot organization. And what that means is we operate with over 800 volunteer pilots, and they utilize their own private aircraft. So these are small general aviation planes, about 4 to 6 seaters, give or take a couple jets in our fleet. They pay for their own fuel, and they use their own time, and making it completely free of charge for the patients. Their passion's to fly, but they want to do it with a purpose. So, you know, that's why we have such a huge roster of them. They're just really great people who want to give back. We also work with some corporate sponsors like Southwest Airlines. They actually donate a certain amount of vouchers to us yearly that we can use for further flights. And our main goal is to eliminate the barriers that comes with needing to travel further distances for medical treatment. We've worked with NORD for several years, and we've made some great connections all around the country with different communities. Ones that I can think of specifically are the Batten disease community, 22Q&U, and Beckwith Weidman syndrome at CHOP. They have some special programs that I believe, you know, for these rare diseases that many people from all over the country and even world go to. So for the rare disease community, we know that a lot of the time the best treatment isn't local. And like some of the speakers who previously spoke on this call said, you know, wrong diagnoses are very common, and sometimes you do need to travel a little bit further to get to the right doctor who really specializes in your condition. So that's where PALS comes in. So, you know, obviously everyone wants to get to the best treatment for them or their child, and we're happy to help in that journey. And you can go to the next slide. So this is the impact of our first 10 years. We have been an organization for a decade now, and we just celebrated our 10th anniversary in November with a virtual gala. It was very successful. You know, usually we have galas at catering halls and a lot of people attend, so we were a little nervous, but it ended up being a really great event, and we raised a lot of money for our community, which was great. And when we started out, just to kind of demonstrate how far we've come in the last decade, we started out flying in just the Northeast region of the country. That's, you know, our one office is based on Long Island, and that's kind of where we accumulated pilots at first in New England and whatnot. And in the last 10 years, we've been able to expand as far south as Florida and as far west as Wisconsin. We actually just completed our first flight from Virginia to Wisconsin, which was really exciting. We've been working really hard to acquire volunteer pilots in all of these southern and western states, and it's really amazing to see it flourishing. Our data really speaks for itself. As you can see, we have helped over 2,900 families with over 23,000 free flights. Our veterans, the 900 veteran flights that we do, that's a special veteran program that we have, flying military personnel and veterans to different retreats. I won't really get into that because it's not super applicable to this presentation, but we do have some other programs like our veteran and compassion flight program. The compassion flight program, we actually can help friends or family members of patients who would like to go visit them or whatnot, who aren't patients themselves. We can fly them to go visit their, you know, a loved one in a facility or whatnot. So that's another great program that we offer. And altogether, we have flown over 5,400,000 miles for our patients. You know, acquiring pilots and patients in states we've never flown before means we can expand our resources to so many more patients in need across the country. And for the further flights, like I said, Southwest has donated vouchers to us, which they do every year, and we're able to you know, fly further than the territories that our volunteer pilots fly into. So, you know, a cross-country flight would qualify for a Southwest voucher. And you can go to the next slide. So this is just one of our patients, Hadley. She's been flying with us since, as you can see, on her third PALS flight since she was a little girl. And recently, I believe she just turned 17. She's a senior in high school, and she's been flying with us ever since. She has a rare cancer, and she goes from her home in northern Maine to Dana-Farber Cancer Institute in Boston. And you know, we just put this in here to show how we try to support everyone throughout the duration of their medical journey. She actually spoke on our virtual gala back in November and shared a little bit about her story and, you know, just just to kind of emphasize that we're not we have you know, the capacity to fly people an unlimited amount of time. So a lot of our patients need to go to clinical trials, and we have patients who need to fly with us every week, and we're able to provide that for them. For the vouchers, since we only get a certain amount of them, those do have limitations, but, you know, we try to survey everyone on an you know, on a case-by-case basis, just to see, you know, maybe someone needs to go one more time or two more times than allotted with the vouchers. We really do try to accommodate as best as we can, because we know that for, you know, people who are battling different diseases, it's not just, you know, a one and done trip. It can be throughout the span of a couple years, just like little Hadley, not so little anymore. But let's see. And I believe that's, you know, that's really it about our programs. Yeah, the next slide. And what I would like to share is my contact information. I would love to encourage anyone interested to send me a referral or even just an inquiry. I'll provide my contact information in the chat box. The intake process is really simple, and it does require that the patient be ambulatory and able to walk onto a small aircraft. So unfortunately, there's no medical attention on board, and we do have one stretcher flight in our fleet as however, so you know, we can you know, sometimes make more medically complex patients, we can sometimes make that happen. You know, the patient does, since it's a small aircraft, the patient does need to be able to sit upright and buckle in. We've put in place some new COVID protocols. You know, the private flights that we offer are very ideal, especially during the pandemic, for the immune compromised patients, which is great. And we have put several COVID protocols in place, like wearing masks on planes and whatnot, you know, to try to make our flights even safer and especially as safe as possible during COVID. We do ask for 5 business days notice, you know, to submit a request to us, but we, you know, in places that we have a huge volunteer pilot community, we are sometimes able to work some miracles and get requests in shorter time than that. So, you know, I just encourage anyone who has any questions or think they could really benefit from the service, or, you know, they think that they, you know, they're not sure, to reach out, because we really do try to accommodate and help as many people as we can. And, you know, we just want the rare disease community especially to know that we are here to help. And I would love to answer any questions that you guys have. So that's about, you know, that's about it from me. But I look forward to chatting with you guys in the chat box, and providing my contact information if anyone else wants to reach out to see if they or a loved one qualifies.
Thank you, Suzanne.
Thank you.
Yes, I appreciate you being here today. And we do have a little bit of time for questions and answers. I don't know.
Right just before we open the lines and we'll do I just wanted to give a shout out to Rose on the call. I don't see her in the window anymore. You guys are striping it out today. You have the best zebra spirit today. So if you can message me your address, we're going to send you a little gift.
Thank you.
Whoa, look at that.
I just had to recognize you guys. I love the hat.
I'm jealous.
Bless you. Bless you.
Okay. Oh, so I don't know if any questions have come up in the chat room or not, but we do have a little bit of time. We've had a lot of wonderful speakers today. So if you have questions, here's your chance to ask them. Anyone?
Well, I can just add, you know, thank you, Patricia, for all the hard work on putting this event together, and for all our speakers today and sharing your stories, information. I learned a lot, you know, and you know, some great resources that we'll be able to share with other rare disease patients that come through our door here at NORD. So that's great. And, you know, I highly encourage everybody on the call today to stay connected to Patricia, get more involved with the North Carolina Rare Action Network. You can visit rarenc.org, and actually believe she's got a slide.
Yeah. I see we've had a couple of questions.
Yeah, we have a few questions here. So the first one is from Amber. So what is NORD doing to help expand Medicaid access in North Carolina? So that is a great question, and that is definitely a policy issue that we focus on. We feel that Medicaid expansion is really important for the rare disease community. So we'll definitely keep you up to date if you are a North Carolina RAN member on any upcoming legislation or action we're planning on taking during this session. But absolutely something that is very important to us as a policy team.
And can I just add too, I know it's been a priority for our governor to do Medicaid expansion. There's about 500,000 people here in North Carolina, not all of whom obviously have rare diseases, but about 500,000 people who would benefit from Medicaid expansion in our state right now. So it is kind of on our plate as a priority.
Perfect. So the next question here is, I apologize if this is not in the scope. Do y'all do any work with trying to get new diseases on the cow? So that's something that I actually need to look into. And if you want to shoot me an email, I can do a little bit more digging. I don't believe that we do at this time, but I can look into that. See if we have any other questions.
Are there any others?
Great, and Suzanne provided her contact information.
Okay. And then, I don't know, Kristen, if you, yes, that's fine, thank you. You're reading my mind. So we are gonna have a raffle. We're not having it today. We will have it in a few days when we have all the attendees, the full list, so we can choose 2 attendees who will receive a swag box with all these wonderful gifts in it. And you can expect your swag box to arrive sometime in mid-March. So we will let the winners know later this week.
Possibly today or tomorrow. We're not excited. We have a lot of events this week, so we didn't want to give a specific time. You may get an email.
You may get an email today, or you may get it tomorrow, but definitely by Friday.
Great.
Okay. And
we do have one final message that I'm going to share.
I wanted to do before we did that. I wanted also to acknowledge and thank Sharon King, who's here today. Sharon and Taylor's Tale. Because of them, the Wells Fargo Duke Energy Center in Charlotte will be lit up for Rare Disease Day with the rare disease colors. So thank you for Sharon for handling that. And we'd also like, if anyone is in the Charlotte area, if you could also promote it through your Facebook or Instagram or however you would like to promote that, to let people know that the Energy Center will be lit up on the 28th, which is a Sunday evening, for Rare Disease Day. And I'm going to put the link for the story for that in the chat room.
All right, we'll close.
Every year on the last day of February, the National Organization for Rare Disorders joins together with others around the world to raise awareness of the challenges faced by people living with rare diseases. Achieving health equity is even more difficult for rare patients. To have equity in health means everyone has an opportunity to be as healthy as possible, regardless of social, geographic, economic, or other obstacles that may be working against them. At NORD, we appreciate your support, which allows us to work on issues like health equity and many others and for our staff and volunteers to bring them to the forefront on Rare Disease Day.
From the volunteer state ambassadors, we would like to say thank you to all of our Rare Action Network supporters for helping us connect with rare patients and families in our state.
And thank you for allowing the Rare Action Network to raise important issues with state lawmakers on Rare Disease Day and throughout the year.
Did you know that in medical school I was told when you hear hoofbeats, think horses, not zebras? What about the more than 25 million Americans living with a rare disease? At NORD, we are humbled to provide help and resources to our zebras and their caregivers.
NORD support allowed me to catch up on some overdue bills, including my rent. Thank you for your support, NORD, and thank you for supporting Rare Disease Day.
From all of us at NORD, thank you for your dedication to the rare disease community on Rare Disease Day and every day.